Kenneth Weeks, Editor-in-Chief of the Cardiosource Clinical Community on Sleep Apnea and Cardiovascular Disease. It's my pleasure today to introduce Jaspal Singh, MD, Clinical Associate Professor of Medicine and Medical Director of Carolina Sleep Services. Dr. Singh, thanks for being with us today.
Thanks for having me.
I know that you practice pulmonary medicine and have a great experience in using PAP therapies for treating patients with obstructive sleep apneas. Tell us, if you would, what the current technologies that you believe the public and our patients should be aware of regarding positive airway pressure therapies.
Positive airway pressure therapies, Katie, have come a long ways. It used to be the traditional CPAP. CPAP is just basically what would deliver a continuous positive flow of air pressure. And in the old days, or 20, 30 years ago, that was when it was first being diagnosed, sleep apnea was first being diagnosed and treated. CPAP itself was fairly bland in terms of how it was delivered. Over the last few decades, though, we've seen some significant advances, not just in the way the air is delivered, but also the masks, the tubing, and a bunch of other paraphernalia regarding the devices themselves. Traditionally, a lot of patients with sleep apnea, you'll hear a lot of negative thoughts about CPAP. You'll hear patients say, oh, I tried it for a while, it didn't work well for me. But a lot's changed, and I think a lot of patients would be surprised with the newer advents and advances in CPAP therapy, what's improved. The major improvements have been the number of masks and the types of masks, as well as the materials the masks are made of. Things like humidification of not only the mask itself and where the air comes out, but also in the entire tubing itself now being climatized or humidified along its entire route. So there's not as much problems with condensation with the tubes. The way the air is delivered now is also getting more sophisticated. It used to be just CPAP would just blow a fixed amount of air, and when the patient's inhaling or expiring, the same amount of air pressure is going both ways. Well, now there's newer ways of pushing the air forward. One of them is sort of where the air pressure relaxes. We call that expiratory pressure release, or some device manufacturers call that C-flex, where the patient, as they're exhaling, the pressure drops, and then it gradually increases again. That's just one advance. Another major advance has been what we call bilevel therapy, where the pressure actually changes whether you inspire or expire, and also you can actually set the pressure's inspiration and expiration can actually automatically adjust based on the device's airway mechanics. This latter advance, or the auto component of this, has really undergone some major advances recently, and it's pretty amazing now where the CPAP devices really can self-adjust and really can sense if a patient's airway is actually not being well treated or not being well opened, and it can adjust the amount of air delivery. And it can also lower it when less air is needed. And a lot of my patients find that very comfortable and very comforting to know that they're not getting more air than they need to at given times.
Dr. Singh, we know that many patients either poorly tolerate or don't stay with PAP therapy. What other therapies should our patients be aware of besides PAP therapy?
Right. Well, PAP therapy is just one therapy, like you stated, Katie. And I think for a long time, the sleep community was focused so much on PAP therapy, we sometimes lose sight of other therapies. One of the more common therapies is just straight medical therapy. Medical therapies include things like minimizing any muscle relaxants, which are very commonplace these days. Things such as anxiety medicines can affect sleep apnea, so minimizing those can help. Decreasing the amount of sleep aids that people use can also help. Improving the position of your sleep. We know, for example, that sleep apnea is worse when someone's on their back. Well, sometimes people can actually sleep on their sides, and a lot of our patients do that almost naturally. They learn to adapt to it, or their spouses push them on their sides, for example, and that minimizes their snoring. But there are a bunch of different therapies, such as medical therapies, that can be helpful. One of the most common ones that we really advocate for is aggressive weight loss. We are, generally speaking, an overweight society. in our country. And for our country, sleep apnea is very intimately linked with obesity and the obesity epidemic. So we really encourage weight loss, diet, and exercise, in addition to the things I mentioned before, and especially for patients that are either have mild sleep apnea or will not tolerate CPAP therapy. In fact, In fact, one of the things we oftentimes advocate for in our very obese patients who are completely intolerant of CPAP therapy is actually bariatric surgery, which has come a long ways and has been shown not only to improve things such as weight loss itself, but also sleep apnea, diabetes, and other conditions as well. So we're not saying that weight loss surgery is for everybody, but weight loss itself is of paramount importance in the medical treatment of sleep apnea. Other therapies, though, have also come a long ways. One of the ones that's most evidence-based proven to be efficacious for sleep apnea, especially in the mild to moderate cases, are what are called oral appliances. And I'm sending a lot of patients these days for oral appliance therapies. Now, an oral appliance therapy moves, as the slide shows, in a way that it moves the jaw forward, and the patient learns to sleep with this fancy bite block, you might say. By moving, this bite block actually positions the lower jaw forward, moving the tongue and the soft palate forward, and allowing the patient's air to move through the posterior airway almost as well as CPAP, and in some cases just as well as CPAP. It just depends on a variety of things. It depends on the patient's contour of their face, their anatomy, their physiology, and they also need an oral appliance specialist who understands these devices. There are a host of them, and I counsel my patients that if you're going to spend the time and the energy in doing these, you want it to be done by a dentist who really understands what they're doing, or an oral surgeon or their office who really understands how to place these in and how to adjust them.
Thank you, Dr. Singh. This is excellent. Before we close, I might ask you if there are new research protocols out there, such as the tongue stimulation, that may be part of the future. Can you briefly comment on that modality?
Yes, hypoglossal nerve stimulation has been getting a lot of press, and the way that works is by stimulating the hypoglossal nerve, almost like a pacemaker, to the back of your tongue and to the lower part of the soft palate. The nerve stimulator creates increased tone, so you get more of a rigid tone when the airway starts to collapse. It's almost like a fancy pacemaker to that posterior muscle, but a lot of us are a little bit concerned before that becomes more recommended, that the FDA look very carefully at the indications and the research based on the hypoglossal nerve stimulators. But the technology itself has some promise. The other thing that's potentially promising are what we call nasal EPAP valves, or basically these nasal prongs that allow patients to breathe in but don't allow them to breathe out as effectively. And what that does is that traps air in the back of the pharynx and keeps it open. Some patients tend to like this. They're fairly expensive by one company that has the predominant market in this country, but I do have patients that sometimes ask about these devices, especially those who travel a lot and don't want to take their CPAP with them.
That's excellent. Dr. Singh, that's all the questions we have for you this morning. Thank you so much for sharing your understanding of PAP therapy and its alternatives for our patients with sleep apnea.
Thanks, Katie.